during the course of the agenda this morning. So shall we move on? And in accordance with the rearrangement that we agreed earlier, Arvind, you've had your cue from Simon. May I invite you to talk to the paper on general practice services?
So, thank you, Malcolm. The purpose of the paper is to provide an update on progress to date and the key next steps. And by way of background, we're all acutely aware of the pressures general practice is facing from rising demand and case complexity. And whilst patient satisfaction remains high at 85.2% of the public reporting a good experience, this does mask a number of significant challenges around recruitment and morale and other areas. The General Practice Forward View was published on the 21st of April and includes 80 practical funded commitments grouped into 5 key areas of focus: investment, workforce, workload, infrastructure and care redesign. It's a 5-year programme that sets out an increasing investment profile culminating in a recurrent 2.4 billion per annum by 2021, aimed at both strengthening general practice in the short term and supporting a more sustainable transformation of primary care in the future. And it builds on emerging solutions around self-care, working at scale, use of technology, use of the skills and capabilities of both the clinical and non-clinical workforce. So in the last 14 weeks since it was launched on the 21st of April, I'd like to share with colleagues some of the things that have been happening. So we've already started delivering against some of those 80 commitments, a new scheme to help doctors returning back into general practice, including relocation costs and educational bursaries. We've begun the procurement exercise of the service to help GPs facing stress and burnout, and aim to have this service available nationally up and running in December. We've started processing CCG applications for the Primary Care Estates and Transformation Fund, and that will establish a pipeline of investment in primary care. In addition, the NHS Property Services Standard Lease has been agreed, which includes a commitment to fund stamp duty land tax for practices underpinned by an investment of 7 million. We've established the GP IT operating model, which is backed by an 18% increase in CCG allocations for the provision of IT services and technology for general practice. And on workload, we have now, today, we will be issuing a letter jointly with NHS Improvement detailing out the responsibilities to NHS trusts and CCGs in relation to the changes in the standard contract made in 16-17 and reminding them of the responsibilities around this. And this is particularly important as it will reduce the number of unnecessary patient journeys to hospital and also some avoidable workload for practices. We are also establishing a new multi-stakeholder primary care interface group which will drive efficiencies in the current working arrangements between general practice and hospitals. In terms of next steps, the first 16 million of the 4-year 40 million general practice resilience programme is being devolved to local area teams to help struggling practices across the country now. This programme builds on the work that's already underway in relation to the Vulnerable Practices programme, but the scope will be increased so that actually we can mobilise rapid intervention for practices at risk of closure, a wider menu of support options that are available to more practices and going upstream of when problems arise, helping with workforce issues and engaging experienced clinical capacity into those local health economies and helping them develop skill mix solutions, and actually working beyond individual practices with groups of practices in troubled areas to prevent, when one practice is struggling, the domino effect of others coming under significant pressure, and removing the requirement for match funding from practices to engage with this support. We're also releasing details of the 3-year £30 million general practice development programme, which will give every practice in the country eventually over a 3-year period the opportunity to develop, to benefit from the organisational development support contained in that programme. That will mean running local time for care programmes in each area that last 9 to 12 months with intense workshops and a variety of other engagement activities that include rolling out the 10 high-impact initiatives, which were innovations that were developed during the General Practice Access Fund schemes, with an ambition of eventually releasing 10% of clinical time for GPs. Linked to this, we're setting out our plans for training receptionists and clerical staff to play a greater role in navigation of patients through the system and handling clinical paperwork burden within practices, and plans for the online consultation system and uptake of that. We've also been working with the Department of Health and the profession and medical defence organisations to consider proposals on indemnity. Now, this is a complex area, so we are taking a twin-track approach to how we're dealing with this. Firstly, to alleviate the immediate pressures, we will introduce a new indemnity support scheme for practices for at least the next 2 years. And this will build on the work that's already happened in relation to last year's GP contract, where an investment of £33 million was made into the contract to support this particular pressure, with a similar amount in the coming year, payable in April 17 to practices, and again in April 18. The area of out-of-hours indemnity cost is particularly complex, and work will be carrying on this year to establish a way forward. However, as a holding arrangement, we will continue the winter indemnity scheme for this year. Given the complexity of this particular field, alongside this, we'll continue work with the Department of Health and others, including the NHS Litigation Authority, to look at the scope for more fundamental reform in the system during this period. On the retained doctor scheme, we are increasing the allowances payable to both individual doctors and the practices hosting them. In addition, on workforce, we're working with Health Education England to increase the pool of GP applicants, particularly from medical schools across Europe that train in English and where a lot of the students are in fact UK citizens. The board will be reviewing a separate paper shortly on the multi-speciality community provider framework, but just to say that we're working with the NAPC, the National Association of Primary Care, on building on their primary care home initiative in the coming year, over and above the 15 sites they already have running. We'll be commissioning list validation work with a view to investing any savings that may be made back into general practice. And lastly, we've established an external oversight group, including the Royal College of GPs, the General Practitioners Committee, NHS Clinical Commissioners, the Queen's Institute of Nursing, and National Voices, to give us some overall steer and oversight into the activities that we're rolling out through the General Practice Forward View, and that is supported by the Royal College of GPs having recently employed 29 regional ambassadors to support that work in each of the areas, and we've started a reference group with the LMCs from around the country where we can have rapid feedback on whether the changes that we're rolling out through the Forward View are having impact. So I'll stop there.
Great, thank you very much, Arvind. Let me invite questions and comments to Arvind from the board. Bruce?
Thanks very much, Chairman. Can I just perhaps put a little bit of context around this and indicate why we're doing it? Because you might think that most of this is focused on GPs, but the reality is by focusing on general practice and primary care, we bring benefits to our patients, and that's the end game in all of this. Our GPs are dealing with increasingly complex patients. The demands are going up at all sorts of levels, and they're functioning in a very different societal environment to a decade ago or 2 decades ago. And so general practice has changed, and it seems to me that one of the real challenges we have is that the art and science of medicine come together in a combined endeavor in general practice, not just to treat individual diseases, but also to treat the families who are affected by those diseases and the communities in which those diseases occur. And we're increasingly asking general practitioners also to become engaged in the prevention agenda, which is clearly very important. And in real life, it seems to me that they have to be on constant alert for minor ailments that are masquerading as pretty serious diseases. And there is a changing set of expectations that they don't miss those diseases. So the end result is that general practice is clinically, intellectually, and emotionally demanding. It's emotionally demanding in part because of the clinical environment, and also in part because of the bureaucratic environment in which they have to function. So there's nothing kind of general about general practice. And as patients have moved out of hospital to be treated in the community, we've seen a commensurate requirement for the professionalism of general practitioners, who have increasingly become the general physicians, the consultant community physicians of the day. And that's a very important change in my view. And yet at the same time, I think there's evidence that our general practitioners have been undervalued by the NHS at the time that we need them most, when we're asking for them to do more. Their income has dropped very significantly in real terms since 2005-06. During a similar kind of period, the number of consultations of increasingly complex patients has gone up by 14%. And there are a set of expectations which have accompanied that, expectations which GPs have imposed on themselves to ensure that they provide the best quality clinical care that they can, but also a set of expectations which come from patients and those that oversee the NHS. Equally, as has been pointed out in the 5-year forward view, during a similar period of time, we've seen levels of investment down by 0.8% annually in general practice, whilst it's risen in hospitals by 12.3%. And there seems to be an inequity in that. And much of this becomes reflected in the longitudinal work-life survey. We know that morale in general practice is the lowest that it's been since 2001. And then when you start to dissect that out, you see that it's due to a feeling of excessive workload, unresourced work, which has been moved out of hospitals into general practice, not enough time with patients, which is really important if you're going to engage in the sort of relationships that you need to deliver the kind of care I've described, and the weight of regulation. And this is also reflected if you look at the proportion of people who are leaving general practice early, retiring early. It's up 10% for the ages between 55 and 65 between 2004 and 2014. And that's a combination of dissatisfaction with the working environment and complicated further by pension considerations. And on top of that, it's made it more difficult to recruit people into general practice. So despite all of this, it's worth noting that the general practice outcome standards have improved over the last year in 30% of practices. So we can't afford to keep on losing our general practitioners, and we can't afford to have a disenchanted general practitioner workforce. And that's what the 5-year forward view is about, and that's what the endeavours that Arvind has outlined are about. And the reality is that the best way of looking after our patients in the community is by looking after our general practitioners and primary care. And that's true both for our current patients and for our future patients.
Thank you very much, Bruce. I mean, I really should have invited you to have spoken in the different order, because you've laid the foundation for the very issues that Arvind was addressing through the general practice primary 5-year view. And then in a moment when we'll invite Ian to talk about the MCP model, then we get, I think, a supplementary leg of our approach to the issues. But let me then invite members of the board to raise issues with either Bruce or with Arvind. I have Moira and David. Moira?
Thank you, Malcolm. Just to say, it is very encouraging that there is such a coherent programme of investment in, obviously, an incredibly important part of the NHS. I just wanted to ask, because it's a variety of things, will we be able to track what's making the difference? Because although you've referred to history in terms of low morale, and there is a kind of cyclical process where it seems to me that primary care gets abandoned and then focused on again, but knowing which of these things have made more of a difference. And secondly, really around the kind of scale of, Simon referred to the Brexit unit within NHS England and the scale of the recruitment. Does it begin to match anything like the potential loss we might have through EU citizens not being able to be here?
So in relation to the first question around tracking, and this is particularly key because actually I think the majority of the audience who view the general practice forward view from the perspective of primary care would say actually these are a laudable set of commitments that are not particularly contentious. Most people would be in agreement with them. Where the issue becomes a little less clear is actually, are they really going to be delivered, and is it really going to have an impact? And actually one of the things that we're looking to do within the implementation group is actually track the progress of each of the 80 initiatives across each of the CCGs and give visibility to that exercise to others within the system and other stakeholders who have an interest in this space to actually create, if you like, a single version of the truth of actually how are we doing, and actually is it making a difference, and is everyone in agreement that the initiatives we think are happening in particular areas are indeed happening, and actually how do we unpack some of those situations and look at them where there is less agreement. So actually we believe that this will drive some transparency through the system, some assurance, and actually the ability to create the ability to learn from neighbours who are actually having some success in particular areas. We're not keen to make that a performance management approach. We want to make that a sort of supportive learning approach to actually how do we roll out something that we think is the part of the right solution for general practice. And we should stress that this is a turning point. This is the beginning of an exercise, and actually the transformation that we're proposing is pretty ambitious and pretty substantial and will have implications for other parts of the NHS too. But it's a step in the right direction. In relation to the area of recruitment, it's a particularly challenging place when, as Bruce has highlighted, morale is at its lowest since records began in 2001. And statistics around how many GPs are looking to leave the profession in the next 5 years is somewhere around a third through self-reporting, and that jumps to somewhere around 60% over the age of 50. So we have quite a challenge hardwired into the existing demography of the workforce. However, with the efforts that are being made around recruitment, and Health Education England have reported that they've recruited more GPs this year than ever before, the measures that we're taking around workforce, around retainer schemes, returner schemes, trying to reduce the bureaucratic burden of re-entering the workforce after a break, and the sort of mix of portfolio options that we're going to be rolling out for doctors towards the latter end of their career. So, for example, there may be some overlap in how a GP who's looking to do less sessions towards the end of the career, we can lock in that experience to the system by perhaps having them work in resilience teams within areas and deploy some of that experience to practices that may benefit. So there's a variety of things that are happening that are hoping to turn that situation around, but we have the ambition of 5,000 additional doctors in general practice by 2020-21.
David, and then Wendy.
Thank you, Arvin, and thanks for that presentation. And I think this is at the heart of the change that we need to effect the transformation of primary care. So it for me, mission critical. So my question is less to you and more to Paul and to Simon, actually, which is underpinning this programme is a significant increase in the amount of money going into primary care over the next 3, 4, 5 years. Well, every year, but over that period. And historically, primary care has been suffered when it's come to balancing the books, etc. And therefore, I'd just like to maybe Simon or Paul, just to maybe just tell us how you're thinking about that and the extent to which we can be assured that the commitments that have been made will be matched by the money.
So the money that Arvin's talked about is absolutely firmly ring-fenced within our budget. It's clearly stated in the allocations that we've agreed upon. It's preceding the allocations. Where they haven't already gone out, will go out as soon as we're ready to confirm where they should go to. So I think we can be totally assured that the transformation money for primary care will go. To be very clear, primary care in its routine budgets has set aside the 1% that's required of all commissioners, and clearly that part of it is dependent upon the overall performance of the system. But when I come to my financial report later on, I'll be trying to stress the actions we're taking to make sure that that 1% too, both for CCGs and primary care, is kept intact for doing transformational purposes rather than being used for offsetting purposes. But I'll come back to that if I may when I do the finance report.
Okay. Simon,
Well, as I mentioned in my written chief exec's report,
Trying to decode
David,
it.
right? Well, I mean, it's not too coded. I mean, it sort of says, we've been in a period where, in effect, individual organisations, individual hospitals were kind of, choosing their deficit and then expecting somebody else to pick up the tab, given that we live in a nationally budgeted system and Parliament sets the amount of money that the NHS overall gets to spend each year. And the consequence of that has been that somebody else, namely mental health services and primary care, have been suffering as a direct effect. And that's not right for patients, it's unfair to staff in other parts of the system, and it's inconsistent with the requirement on boards and managers to be effective stewards of the public resources that they're actually in charge of. So we've got to change that, and the word that we've used for that is reset.
Good, thank you very much. Wendy?
Yeah, no, I'd like to just echo my colleagues' congratulations. I think it's a very exciting paper, and the breadth of the program is outstanding. The question I had, I was very encouraged by the number of people providing oversight and the fact that we're continuing to bring in other groups to support us in this. And I was very encouraged by the ambassador program that's been laid out, because I think it's so important that the voice of the GPs comes to the program as well as the other KPI tracking. How will their voice be incorporated in, and how will we continue to learn from feedback from this important population?
Yeah. So, well, the Royal College of GPs has, as I've said, announced 29, and I think they're looking to employ another 4 or 5, so they have full coverage. And actually, we have been involved in their induction program to ensure we bring them up that learning curve as quickly as possible in understanding the sort of architecture of the system and where they may have the ability to input and have influence. We've made direct introductions to our directors of commissioning operations in each of the regions so that they're connected with the NHS England teams quite quickly, and we've made introductions for them to join the teams that are developing local sustainability and transformation plans. And they're also key participants in some of the events that we're holding nationally around the country to raise awareness of all the moving parts of the general practice forward view, and actually become the sort of local point of contact for a lot of GPs in those areas as an information source for the queries they have around it. So we very much want to bed them into the structure, and we're really grateful to the Royal College of GPs in terms of making a step of this level in terms of its commitment to this direction.
Thanks, Chair. Great paper, and thank you very much. And one of the things for me that's really positive about this is that it's about a general practice 5-year forward view which encompasses the whole of the team, as it were. And I think Bruce has very clearly outlined why it's so important that we provide the additional support for GPs, and I think that's absolutely right. But I just wanted to flag, and I think most people will be aware that that the team is obviously wider than GPs, and what's really positive for me with the forward view is that it does talk about the wider team. It recognises the role that other healthcare professionals like general practice nurses play, and there are some specific actions in there to enhance that role, to talk about return to practice, and more importantly for me, actually look at pre-registration clinical placements for student nurses, so that what we're talking about, this is actually a place that people want to work. They want to do that. That is where they see the future career, because the opportunities to support patients in primary care settings in their homes is absolutely phenomenal, and we really should be encouraging that. So I just really wanted to emphasise that this is a general practice forward view and something that the whole team are a central part of.
Good. Thank you very much. Arvind, can I just, on behalf of the board, say thank you again for the paper. I know you've worked closely with Ros Rawson on this, but I think the board is dead keen to continue to track the progress of rolling forward the general practice forward view. So your assurance on the tracking mechanisms, I think, is very welcome. I would commend also the very close working with the Royal College of General Practitioners, I think, as an overall demonstration of our seriousness about general practice. This is a critical partnership that's worth building on and developing. And picking up Jane's point that it's not just GPs that we're talking about the whole team that deliver general practice. And I think we would like to have further reports coming through over the coming year to ensure that we're on target with what we're trying to achieve. And picking up on all those points that were so well made by Bruce as to the fundamental importance of general practice in what we seek to deliver.